Dear colleagues, I'm Benjamin FOURNIER. I'm a pediatrician at Necker Hospital in Paris, and I will discuss EBV and immune dysregulation. So, as you probably know, the EBV virus is infected almost all the population worldwide, and it's important to understand that the physiological target of EBV are B-cell lymphocytes. And the goal of the virus is to persist all the life of the individual that he has infected, and it will persist in memory B cells. And there are frequently asymptomatic reactivations in each subject, and you may objectivate this reactivation by PCR in the saliva and less frequently, possibly in blood, but at low levels. And there are several EBV-related diseases, and the most frequent are logically related to EBV-infected B-cell lymphocytes, such as infectious mononucleosis or lymphoma, but there are also diseases related to EBV-infected T or NK cell lymphocyte, in which we will be more focused here, and which are EBV-positive T NK cell lymphoproliferations. So for the rheumatologist or in internal medicine, which are the diseases that may be linked to EBV, and here I will exclude the hematologic malignancies and the solid tumors. So this disease, there will be almost always a positive blood EBV PCR, and it's still important to differentiate the cell that is infected by EBV, either B-cell lymphocyte or a TNK cell lymphocyte, because this is not the same pathophysiology and the treatment won't be the same. So very quickly, for EBV-infected B-cell lymphocytes, you may encounter this disease during primary or secondary immune deficiency, and with phenotypes such as macrophage activation syndrome or B-cell lymphoproliferation. And these patients may also have phenotypes related to autoimmunity, autoinflammation, or allergy, but these phenotypes are not directly linked to EBV. They are mostly linked to the underlying immune deficiency. And you may also have patients with well-characterized autoimmune or inflammatory diseases who may have immunosuppressive treatment, and in these cases, there may be a reactivation of EBV, which are mostly asymptomatic. And here I will be more focused on the other subsets of disease, which are EBV-infected T or NK lymphocytes, and thus these are EBV-positive T NK cell lymphoproliferation. And these patients may have hemophagocytic lymphohistiocytosis, but they may also present with phenotypes that will closely mimic dysimmune or autoinflammatory diseases. So these EBV-positive T NK cell lymphoproliferation, there are several subsets that are now quite well defined, which are, the first subset is chronic active EBV infection, or CAEBV, T or NK type, and which may be divided into two subsets: cutaneous CAEBV with Hydra vacciniformis and severe mosquito bite allergy. And there is also systemic CAEBV, which is a group of very heterogeneous inflammatory and dysimmune diseases. And what is difficult with these diseases, especially systemic CAEBV, is that they may evolve for months or years, but the evolution is unpredictable. And over years, these patients may evolve very suddenly toward EBV-positive TNK cell lymphoma, overt lymphoma, or sometimes to very severe and fulminant hemophagocytic lymphohistiocytosis. There is also another subset that I won't discuss here, which is systemic EBV-CD8 positive lymphoma of childhood. And so what is very important to understand is that in all of these diseases, the EBV is infected T or NK cells, and these infected cells are always present in the pathological tissue. And there is always also these infected cells that are circulating in the blood. So the EBV PCR in the blood is always elevated and positive. And you may have access to these cells in the blood to analyze the infected subset using either Iberflow fish or PCR unsorted cells. So it's very important for these diseases to prove that the EBV is infected T or NK cells, either using histology or using peripheral blood. And so very quickly, the patient, very frequently, they don't have a familial history, they don't have personal history, and they don't have underlying immune deficiency. It's mostly children and young adults. It is not restricted to Asia. And as I mentioned, the EBV PCR is always high and persistent, and the level of PCR is almost always over 4 log and so always over 5 of 6 logs most of the time. And if you have used rituximab in the patient, you will have only a weak or absent response because EBV is not in B cells. So there are diagnostic criteria that have been established in Japan. So as I mentioned, the first is that EBV viral load by PCR is always elevated in peripheral blood. You have to prove that EBV is in T or NK cell lymphocyte, either in the tissue or peripheral blood, and the patient have systemic inflammatory symptoms for more than 3 months, but it's mostly for months or years. And the patient may also have flares and possibly spontaneous transient remission, and thus very significant diagnostic delay. And you have to exclude overdiagnosis, such as lymphoma or immunosuppression. And so, as I mentioned, there is very significant clinical heterogeneity across patients. There are patients that have relapsing lymphoproliferation. There are patients with disease very similar to inflammatory bowel diseases, some patients with diffuse myositis, some with systemic vasculitis, and there are several other phenotypes, and these phenotypes are often atypic. So now how can you diagnose this disease, especially systemic CAEBV? It means when to request an EBV PCR on whole blood, and how do you raise the suspicion? So I think it's interesting to raise the diagnosis, to raise the suspicion when you have a dysimmune or inflammatory diseases, which is atypical or with unusual severity. The classic markers of the disease are absent, and there may be an association to clinical lymphoproliferation or positive PET-CT. There may be also cytopenia. The disease will persist for months or years, and there may be flares and spontaneous transient remission. So these are rare situations, uncommon disease, but I think it's very interesting because if the PCR in the blood is elevated, is strongly suspicious, especially if it is over 5 or 6 log. And importantly, in these diseases that are chronic, the PCR never gets negative without chemotherapy. So if you have one PCR that is negative, this is not the good diagnosis. But the diagnosis remains difficult because the clinical lymphoproliferation may be absent. If you perform bone marrow biopsy or a PET-CT scan, if it's normal, it does not exclude the diagnosis. And the histology is sometimes reassuring, meaning that the lymphocytes that are infiltrating the tissue are small and almost normal in appearance. And the disease is sometimes indolent and can persist for months or years. So now you have raised the suspicion and you have to confirm the diagnosis. So you have to prove that EBV is in T or NK cells, and you have to stain T and NK cells on EBV using an EBV probe. So if you have access to histology, you can use the EBV probe, and it's always interesting to have histology for the differential diagnosis, maybe for prognosis, but sometimes the clinical condition prevent the biopsy, and sometimes there is no lesion to biopsy. And here it's interesting to remember that the cells are always circulating in the blood, so you can use peripheral blood using either flowfish EBV or PCR on sorted cells. So regarding the treatment, unfortunately, there are no clear guidelines, and the prognosis is quite severe on the long term. This may be due to the particular organ involvement of the patient, such as systemic vasculitis, inflammatory bowel disease, and so on, but also to the very unpredictable and sometimes fulminant transformation toward lymphohistiocytosis or overt lymphoma. So the treatment that we have is so far only there to control the disease. It cannot cure the disease. These are, for instance, JAK inhibitors, cyclosporine, corticosteroids seems to be effective, but it has always to be discussed with a specialist team, and it is not curative. The only curative treatment is allogeneic HSCT, but it's very difficult because we don't know quite well who should be transplanted and when, because some patients are very well for years, but they may evolve very suddenly to severe lymphohistiocytosis or lymphoma. So to conclude, it's important to be able to differentiate EBV phenotypes that are linked to EBV-infected B lymphocyte versus EBV-infected T or NK cell lymphocyte, and more particularly regarding systemic T NK cell CAEBV. These are uncommon diseases, but which are probably underdiagnosed. You may think of it in front of atypical inflammatory or disease phenotypes, and here you should perform EBV PCR, and you should think of CAEBV if the PCR is elevated and high over 4 log, if there is no response to rituximab, and then you have to prove that EBV is in T or NK cells. Unfortunately, there are no standardized treatment, and HSCT has always to be discussed. So I will finish there, and I thank you for your attention.